Okay, good morning. We're going to talk about trauma and diabetes. Definitely a little bit of a different twist. And I'll just give you my first. Again, I'm at John C. Lincoln, and that's my team, and that's our hospital. My first disclosure and my only disclosure is that I did apply for an NIH grant regarding this topic. I recently found out that they denied us this NIH grant. And so I'll go on from there. So diabetes and how I came to have this passion for diabetes came from just simply, I have this routine where I would always ask the residents in the morning before we start rounds, did you get any calls last night? That's the best way to find out what happened. And routinely, the answer would be, oh no, just a couple of phone calls about, glucose too high and blah, blah, blah. I'm like, on who? Oh, Mr. Smith. Well, he had an appy. He's 30 years old. Does he have diabetes? No, he doesn't. So that was sort of routine, but there really wasn't much that I could do about it because I wasn't going to, I don't do fasting plasma glucose, and the patients usually go home the next day or it's a bad trauma. But I would hear these questions, just calls about glucose being too high. So let's talk about type 2 diabetes. It's a serious condition. People say things like, I have a touch of diabetes. I don't know what that is. Or my sugar's a little high. I'm not sure about that. I guess it's like I'm a little bit pregnant. But they're suggesting that diabetes, it's not a serious disease. Well, that's just not true. Diabetes is serious, and it's associated with many serious health issues. Just as an aside, it happens to be Diabetes Month, Diabetes Awareness Month, November, just so you all know. Okay, so what's the problem with diabetes? Well, there's a lot of problems with diabetes. Blindness, infections, heart disease. People argue back and forth what's the number one cause of renal failure, patients being put on dialysis. Is it kidney, is it diabetes, or is it hypertension? I still think we argue back and forth the answer to that. Nerve disease is a problem when your sugar is too high. People have neuropathy, poor blood flow, and strokes. So diabetes is common. It's costly, it's manageable, yet 30 to 50% of people in the population don't even know they have diabetes. And the epidemiology of undiagnosed diabetes and prediabetes among acute care surgical patients and trauma patients is poorly defined. The association between undiagnosed diabetes and morbidity and mortality outcomes among acute care surgery patients remains unknown. And remember, when I say acute care surgery and trauma patients, there's that extreme. A lot of the acute care surgery patients are 30, 35, 40-year-old people who come to the emergency room with appendicitis, acute cholecystitis, a breast abscess, some other infection. 30-year-old people do not go to the doctor unless they're pregnant or something like I just said, appendicitis, cholecystitis, those things. These are the people who don't have a primary care physician, for the most part. So what do we know when it comes to certain research domains? There's a lot of preventative things we do, all right? We've learned about injury prevention from trauma, when it comes to motor vehicle collisions, motorcycle collisions, child abuse. We do a lot of screening, alcohol screening, HIV screening, hypertension screening, falls, domestic violence. But there is no screening for diabetes that's routinely done in a trauma or acute care emergency department practice. We just don't screen for that. Well, why don't we? Well, in 2008, the U.S. Preventive Service Task Force found that there was insufficient evidence to assess the balance of benefits and harms of screening for type 2 diabetes in asymptomatic adults. Also, in the same year, the ADA, the American Diabetes Association, recommendation came out, and it said to diagnose diabetes in children, non-pregnant adults, fasting plasma glucose is the preferred test to use over hemoglobin A1c to diagnose diabetes. So again, to diagnose diabetes, if you wanted to do it, if you think your patient has diabetes, you need to do a fasting plasma glucose. Again, we're surgeons, we're in the operating room all day, and we just don't have time to figure out and make sure that patient goes to their primary care physician, make sure that patient's diagnosed, even though in the back of our minds we're rounding, and again, my residents are telling me his glucose is 180, he's 30, I fixed a hernia. Does he have diabetes? No. We'll tell him he might, and he might need to go and see his primary care physician, but we know in reality that probably doesn't happen. So what was my motivation? Well, in 2009, laying on my desk, I read something that says the ADA recommends hemoglobin A1c for screening and diagnosis. And there the bell went off. All I have to do is draw a hemoglobin A1c, and I can diagnose and find out if my patient has diabetes or not. I think we should do that. So let's talk a little bit about what are some of the interventions that we know we can do in the emergency department, in the ED, that actually we found reduce mortality and help improve outcome. Well, aspirin, acute MI, we give it to you right away. All right. Appropriate empiric antibiotics, 4 to 6 hours. If you can get them those antibiotics, you think they have pneumonia, start it early, don't start late. It's shown to improve morbidity and mortality. Administration of antibiotics with open fractures, alcohol screening. We're still working on that one, but we start right away. HIV screening and referrals, all these things happen in the emergency department. So we do things in the emergency department that can help prevent morbidity and mortality. So we realized there was a research opportunity here. If we could use hemoglobin A1c, and if what we think, which is I really felt that the majority of our acute care surgical patients and trauma patients, although they were young, had a high incidence of diabetes or prediabetes. And so we wanted to determine the utility of using hemoglobin A1c as a biomarker for acute care surgical patients at pre-existing risks for hyperglycemia, infection, longer hospital length of stay. So why A1c? Why use hemoglobin A1c? What's the rationale behind that? Well, A1c is better standardized than plasma glucose-based tests. There's less biologic variability. There's no need for fasting or time samples. It's less affected by acute illnesses, stress, and again, the ADA came out and said it, that we can use hemoglobin A1c as a diagnostic test. And because we know proteins lose a lot of their biologic function when glycated, it's a robust biomarker. So before I moved here in Dallas, we decided to do this. We conducted a single center, prospective, observational cohort study, 464 consecutive patients with no prior history of diabetes who were admitted through our emergency department with either a general surgery or trauma admission. Some of the variables, A1c, hemoglobin A1c, was determined at the time of admission. We drew that in the emergency department. And we also looked at the fasting plasma glucose the next day for comparison. We used the current standard cutoff points for hemoglobin A1c and fasting plasma glucose, age, sex, ethnicity, zip code, city. We looked at all those things. We looked at BMI, alcohol use, smoking, and then we analyzed our data. So it was a wide catchment area. Most of the patients came from Dallas. And I just put this up to show all the zip codes involved. So it's a big catchment area. Again, it's in Dallas, and Dallas is near and dear to my heart, so I always remember that. I'm a season ticket holder, Cowboy football fan. I know we're not doing that well, but neither are you. Okay, so back to the results. So again, if you look at our population, pretty evenly distributed, 22%, 23% white, 31% black, 45% Hispanic, and this is pretty good for our ER catchment. This is those percents that would break down in the Dallas population. So we see a pretty good distribution of what's really out there in Dallas at the time. And this is a histogram which shows the mean age. The key is to focus, sorry about that. The mean age, 35-year-old, okay? Acute care surgery patients, we're talking 35-year-olds. Remember, you're 35, you probably don't go to the doctor unless you need to go to the ER for your appendix or you have a hernia or you get a breast abscess or you're pregnant. Just remember, 35-year-olds, they don't go to the doctor for the most part. Their alcohol use, 47% used alcohol, 35% smoke. Their BMI, their body mass index, the average was 29. If we break down BMI in our patients, the BMI less than 25 is normal weight. BMI greater than 25, less than 30, overweight. BMI greater than 30 is obese. If you look at these two, 30, 40%. About 70% of our patient population was either overweight or obese. And now if you look at the breakdown by hemoglobin A1c, I put this up to show you the histogram. The mean A1c is 5.7. Now if we break this down in our population, if your hemoglobin A1c when you come through the ER is less than 5.7, that's normal, you're not diabetic. If your hemoglobin A1c is between 5.7 and 6.5, that's pre-diabetes. You're going to convert soon and become diabetic. That's 37% of the patients. Hemoglobin A1c greater than 6.5, you're diabetic, you've just never been diagnosed, 8%. So 40%, over 40% of the patients that we were admitting either had pre-diabetes or were diabetic. And remember, these are young patients who average age of about 35. That normally we would do nothing about. We take out their appendix, we tell them your wound looks great and see you tomorrow, or they're in a trauma. We deal with the trauma, we discharge them, and we may, if we notice their glucose is continually high, we may tell them to go see their primary care physician, okay? And whether they do it or not, we don't know. Okay, we looked at fasting plasma glucose. We checked that the following day. And again, fasting plasma glucose less than 100, normal. Fasting glucose between 100 and 126, pre-diabetes. Fasting plasma glucose greater than 126, diabetes based on standard cutoff point. Again, over 40% of our patients would have prediabetes or diabetes undiagnosed. So head-to-head comparison of hemoglobin A1c to fasting plasma glucose, they're clearly not the same. They don't see the exact same thing, and you can see what the comparison is. This, again, shows the same thing in a different format using a graph, the comparison hemoglobin A1c to fasting plasma glucose. And this slide just shows you that they see different things. This hemoglobin A1c sees something different from fasting plasma glucose. The A1c accounts for about 47.3% of the variance in fasting plasma glucose. Okay, so test of association of models. What are the other things that we looked at in our results? So if you look at this slide, this breaks down by ethnicity. Hemoglobin A1c broken down by ethnicity. And so the blue is normal, the red is prediabetes, and the green is diabetes. So pretty consistent step off. 60% of the white patients were normal, which in comparison, if you look at 41% of our black population, and even more interesting, the 48% had prediabetes. So there's some disparities here, and there's a quick conversion from being normal to diabetic using hemoglobin A1c. And you can see the Hispanic population step off pretty similar to the white population. And remember, we know that there's a higher incidence of diabetes in Hispanics and blacks. And this is using fasting plasma glucose. Again, they see things differently if you use fasting plasma, but still the step-off pattern with fasting plasma glucose is pretty standard there. So we did some linear regression. They always want to know, did you do linear regression? Yes, we did linear regression. And so hospital length of stay. Found some very interesting data here. If you look at the hospital length of stay in these normal patients who have no history of diabetes, what we found is those whose hemoglobin A1c was higher, just like we know in patients who have diabetes, they have longer hospital length of stay, they have worse outcome. We found the same thing in our 35-year-old patients with no history of diabetes, that if their A1c was high when they came in, they had a longer hospital length of stay, and that this was statistically significant. If we look at the fasting plasma glucose, we see the exact same thing. If we looked at the association, because a lot of the patients come to the emergency room with an infection, be it a UTI, be it a wound infection, a breast abscess, a perirectal abscess, cholecystitis, whatever that infection is. Those who had a hemoglobin A1c greater than 6.5, we found a strong association between rate of infection at admission and hemoglobin A1c. Again, statistically significant. Again, they don't have diabetes, and they'll tell you, I don't have diabetes. And then we looked at fasting plasma glucose. They see something different. It didn't hold true with fasting plasma glucose, but it does with hemoglobin A1c. So from this study, we concluded that the epidemiology of previously undiagnosed diabetes and prediabetes among acute care surgical patients at a single trauma center was described, and that the utility of A1C compared to fasting plasma glucose in identifying acute care surgical and trauma patients who have prediabetes or diabetes had been demonstrated. And our injunction, that I kind of like to say this all the time, by their A1C levels shall they be known. So we weren't the only ones who came up with this idea. Actually, right here in Maricopa in 2008, this study was published by Kopelman. And basically, he said that hyperglycemia seen in trauma patients should not solely be attributed to the hormonal and metabolic response to injury. Wider occult diabetes mellitus screening for both acute management strategies and long-term health benefits is warranted. We did an additional study here at John C. Lincoln, obtaining hemoglobin A1c at admission to determine the risk of stress hyperglycemia during hospitalization of acute care surgical patients. And we hypothesized that this elevated A1c on admission is associated with an increased risk of stress hyperglycemia during hospitalization of acute care patients with no prior history of diabetes. And the methods we used, we looked at A1c at the time of admission, fasting plasma glucose the next day, looked at the association. And again, just briefly, what we found is if they come in, if you just check their hemoglobin A1c, if it's high, greater than 5.7, 6.5, first of all, they're pre-diabetic. If it's greater than 6.5, they're diabetic. But the incidence of how many times they have hyperglycemia is high, and these are the ones they're calling your intern in the middle of the night, and the intern does something and he never tells anybody. If you don't ask them, if you don't ask the interns and residents what they did, they won't tell you anything. Oh, had a great night. All right, so those are the results, and we concluded from this study that elevated A1c on admission is associated with increased risk of stress hyperglycemia in acute care surgical patients, and maybe these results can help prompt efforts to develop at least an A1c-based protocol for glucose control among our acute care surgical patients with no prior history of diabetes. The future direction is we need to have a multi-center prospective observational cohort study to provide the evidence that we need for using for the utility of A1c in trauma and acute care surgical patients. We need to determine whether outcomes for acute care surgery in trauma patients with similar ISS are associated with A1c stratified risk groups. And what are the optimal management strategies? I don't know, but we need to try to figure that out. And the most important thing is we can do this and we can identify the patients, then what do? Well, that's where we need the NIH grant so we can follow at least the pre-diabetic patients and see if we can prevent them from becoming diabetic. The diabetic patients, we refer them to our medicine colleagues and let them take care of that. To do this, we need to resubmit this NIH grant, and I need partners to collaborate with me to help me do this, and then we'll pray and hope that they accept it. We can beat diabetes. I beat diabetes. By their A1c level shall they be known. Thank you very much, and I applaud you, DJ, for wanting a wonderful conference.